Good morning, everyone. Welcome to today's free CPD program. Today, we are going to discuss with you how to start insulin in our patient in a simple approach. This is another collaborative session of Sri and Sri Lankan College of Internal Medicine. As usual, we conduct our medicine lectures in this forum. Before we start, let me remind you few housekeeping messages. As usual, we practice. The webinar link will be available from 9 a.m. to 9:45 a.m. to join in. No late attendance will be entertained hereafter. Each attendant should have been attended till the end of the webinar to obtain the certificate for CPD points, and CPD points are strictly adhered to the NCCPD guidelines. It's my greatest privilege and the pleasure to introduce today's speaker to you. He's Professor Arosha Disanayaka, who doesn't need any additional introduction to our medical community. Prof. Arosha Disanayaka is a specialist in internal medicine and professor in medicine at Faculty of Medicine, University of Ruhuna. He is the immediate past president of Sri Lankan College of Ceylon College of Physicians and a past president of Galle Medical Association. He is presently a regional international advisor to the Royal College of Physicians, London. His special interests are diabetes, toxicology, and medical humanities. He is a well-known teacher and trainer in undergraduate as well as postgraduate medical education for more than 10 years, in which we all are inspired of him. Apart from his successful medical career, he is an associate member of Royal School of Music in London and a past finalist of the Chartered Institute of Management Accounts in United Kingdom. He worked as an investigative journalist for the Sunday Times newspaper during his undergraduate days. So without further delay or further ado, let me invite Professor Arosha Disanayaka to start his talk. So, dear sir, Professor Arosha Disanayaka, session is over to you, sir. Thank you. Sir, please switch off on your mic, please.
Right. Can you hear me?
Yes, sir, we can hear you nicely.
Right. Sorry about that. Thank you very much, Himal, for your very kind introduction on behalf of Sri Academy, the introduction as well as invitation for me to speak to this audience today. And then, of course, thank you, Nandini, for on behalf of the Sri Lanka College of Internal Medicine for inviting me for this talk. And then let's get, I hope all of you have received the pre-test MCQ questionnaire. Let's look at that once the lecture is over. Let me do this. Let's start the lecture then. Starting your patient, Himal, if by any chance you don't hear me or any problem occurs, please let me know either through this or my telephone. Please, Himal, okay?
Sure, sir. Sure.
Right. Okay. Thank you. Right. So this is just a kind of very simple talk on how to start a patient on insulin. The purpose of this talk is I felt dealing with many doctors, junior doctors, that their confidence in dealing with a patient on insulin is not all that great. So I've done this, attempted this before as well to improve knowledge and confidence for somebody to actually deal very well with a patient with insulin. Because if you take some country like the UK, it's the diabetic specialist nurses who manage insulin in patients. And I'm a firm I firmly believe that those who do, a general practice after 4 o'clock or who are full-time private practitioners could very well start insulin on patients and manage that as well. And one of my attempts in life has been to transfer some of the specialist knowledge to primary care in the hope that strengthening the primary care doctors' knowledge and skills so that patients in Sri Lanka get a better deal. So let's look at some of this. These are the questions that we will be trying to answer during today's talk. There are about 12 questions, though the list is long, don't worry about it. They are very simple things. Who are the patients who need insulin? what is this concept of OHA failure? What are the routes of administration of insulin? What are the methods of administering subcutaneous insulin? Uh, People talk about animal insulins, human insulins, analog insulins. What are all these types? Are these new posh analog insulins, are they really better than human insulin? What are the different types of insulins if you look at them in terms of duration of action? Most importantly, when you are going to start somebody on insulin, what are the costs? The patient will ask you, doctor, how much is this going to cost you me? Especially if you are doing that in the private sector. And then, so you should be able to roughly calculate and say, you will need about this much for insulin over the coming month. Then what is a normal insulin secretion pattern in the body, and how do we have insulin regimes which actually can mimic that? So what are the insulin regimes that can be used to initiate insulins? And then how should insulin doses be roughly adjusted over a period of time? And a little brief look at what are the essential advices that need to be given to patients being started on insulin. So I accept that the list looks long and daunting, but believe me, it's not so. It's very simple. Let's look at these things. So who are the patients who will need insulin? I just want to look at the time. Right. Who are the patients who will need insulin? One is every patient with type 1 diabetes will need to be on insulin. Type 2 diabetes patients, not everybody, but certainly those who have oral hypoglycemic agent failure will have to be on that. Anybody who's had diabetic ketoacidosis in the past will have to always have insulin, always. Usually DK is a complication of type 1 diabetes, but I suppose in type 2 also under exceptional circumstances in very ill patients, say following an MI or something, somebody can go into DK. But if somebody has DK, in the past, they will always have to be on insulin. Then of course, there is this other category, those who are not yet, who have type 2, who are not yet in oral hypoglycemic agent failure. Maybe even at the time of presentation, those who have severe hypoglycemia, maybe HbA1c 10, 11, 12. Not just that, but those who have catabolic features, where you felt that the patient has been losing weight a lot, etc. So that kind of patient, there is a place for insulin in the initial phase, because if we do not give insulin in the initial phase at least, it is quite likely that the pancreas is likely to get exhausted very quickly, much earlier than a type 2 diabetes patient would be. That's called glycemic toxicity type of thing. So that is one group where you'll have to think about carefully. And then of course, we know that those in the wards who undergo surgery, who have infections, for a short period of time, we may have to put them on insulin. But I'm going to, during this talk today, I'm going to primarily focus on somebody with type 2 diabetes, because that's what you are very likely to be dealing with as a junior doctor. But some of these concepts could be adapted to other things as well. Right. So let's look at what oral hypoglycemic agent failure is. There is no strict definition for OHA failure. The reason for that is in the olden times, we waited till all the medicines were exhausted and then we shifted to insulin. But nowadays, insulin is coming forward every day. So people actually do not wait till something called OHA failure happens to start insulin. But for our purposes, we can say if we fail to meet fasting blood sugar targets, shall we say, less than about 140, or HbA1c targets maybe less than about 7.5 or so, with 4 or 5 maximum dose OHAs, then you might have to consider insulin. So that this is the commonest instance in which we will start somebody on insulin. So you have a patient who is on metformin, maybe 1 gram BD, glycoside 160 BD, sitagliptin 100 BD, 100 once daily, pioglitazone 30 milligram once daily, empagliflozin 25 milligrams once daily. So 5 medicines, and patient comes to you with HbA1c of 8.5. you could always say, okay, I can give metformin, during lunchtime as well. I can probably go up on the pyroglutamate zone to 45. We can probably extend it a little further, but we know for sure that that will never work. So once you get to about this stage, definitely you need to think about starting insulin. The other problem is, if you look at this prescription, this is a very expensive prescription. Empagliflozin 25 milligrams might cost anything like about 150 to 200 rupees a day. That's 6,000 rupees for empagliflozin only. If you give all these for diabetes, you know for sure that the patient will be on rosuvastatin or atorvastatin. For dyslipidemia, patient might be on losartan and maybe amlodipine for hypertension. So if you put everything together on top of that, this is going to be a very expensive prescription. Actually, if you really look at the economics of it, it might be much cheaper for the patient and probably for the country, for the patient to be on insulin. I'm not suggesting insulin because it's cheap, but it's certainly the best option as well. So it can be very inconvenient and very expensive for the patient. And you all know our patients are not very happy to take a large number of tablets. They don't want to take large numbers of tablets. So by this time, patient is also going to be very frustrated with taking so many tablets. Now, what are the routes of administration for insulin? What we would generally see in this country would be subcutaneous injections. But there is something called CSII, that is continuous subcutaneous insulin injection. That's the lot called insulin pumps. That is available in the world, not in Sri Lanka. In Sri Lanka also it came initially, but it was quite expensive when it went out of fashion. And in the initial stages, the pumps were very big, they were quite big and inconvenient. But nowadays the pumps are much smaller. So these things are going to be available soon in Sri Lanka. So we will have to have an idea that these things exist and they are very useful as well. And then of course, there have been some research done on inhaled insulins. That's also a very interesting topic. You don't have to know about it, but just remember that it's a very convenient way of taking insulin, but anybody with chronic respiratory diseases will not be able to take inhaled insulins. So I mentioned all these three things when it comes to insulin administrations, but we will talk today about subcutaneous injection. Right. So what are the methods of administering subcutaneous injections? We have the insulin syringe and the insulin vial, the big bottle, which we have in hospitals. And then, of course, we have the insulin pens and cartridges. If you look at the insulin syringe and the vials, it's a less expensive and it is available in government hospitals. We look at the cost later. It causes more pain and discomfort for the patient than an insulin pen. It's not greatly painful, but it does cause pain. You've all seen those small insulin needles, but they are slightly painful. For many, many years, people used to use those for insulin injection. And then, of course, one of the other big disadvantages is the insulin needs to be stored in a refrigerator, which may not be available in many households in our country. Those days, of course, there was some suggestion that somebody takes a pot and kind of fills it with water and kind of hangs the insulin syringe, the insulin bottle in the pot. But I don't think any scientific research has gone into that to see about the stability of insulin. So we don't recommend those things now, but they will need a refrigerator. So these are the disadvantages. If you look at the pen and the cartridge, there are two types of pens. There are disposable pens, which used and thrown away. They are plastic. I think the picture I have put here, of course, shows reusable pens, but the disposable use and throwaway pens are more expensive. They are useful if you are going to give insulin for a short period of time. Say somebody has sepsis and you want to put them on insulin, and then for a short period of time, or maybe they're undergoing surgery for a short period of time, you want to put them on insulin. Those disposable insulin pens are useful, but they're quite expensive. So what we generally go for long-term use are these metal pens, where we will put the cartridge, which is also shown in the picture, and those cartridges can be put into the pen. The advantages, disadvantages is it's expensive. We'll look at again the cost later. It causes minimum pain. Patients hardly feel this, and it can be carried to. It does not need to be refrigerated. Actually, it should not be refrigerated. It should be just kept in a cool place, and it can actually people can put it in the bag and take it to work, and so they can, if they're going for a party or something, they just put it in the handbag and go, and just before the meal arrives, and they can take the insulin. So there are advantages and disadvantages of the two types, and if somebody can afford it, certainly we should look at giving the patient a insulin pen with a cartridge. Right. Now, there are these three types of insulins. These things can also be confusing at times. For a long time in the past, we had insulin which came from actually extracted organs of animals. That's how insulin was manufactured. We had porcine and bovine. Porcine is from the pig and bovine is from cattle. Of course, people were not very happy, like now anything from pigs would not be acceptable to people of Islamic faith, even maybe for Buddhists and Hindus as well. Even bovine, how is a sacred animal for many people. And so people were very uncomfortable using insulins derived from these animals, and they were not very effective. They used to cause a lot of antibodies. We had a lot of problems, but they're not in use now. Today we have two types of insulins. We have human insulins and analog insulins. The human insulins are not derived from dead human beings or live human beings, but actually they are genetically modified. They are artificially manufactured to look very similar to human insulin. They are not exactly human insulin because that human insulin is unstable outside the body. So they have genetically made a few changes to the human insulin and made it stable and made it available. Now that's what we would generally see in all our hospitals. And I think vast majority of patients with diabetes who are on insulin will be on human insulins. Genetically modified insulins closely resembling human insulin. A small proportion of patients will be on what are called the more posh or the hi-fi insulins, the analog insulin. What has happened is actually people have done research and developed the human insulin molecule that they manufactured earlier even further to become a more absorbable, where the pharmacodynamics, pharmacokinetics, distribution, effect, everything is more. So that's how the insulin analogs came about. They are supposed to be superior to the human insulin, sort of something which is even better than human insulin. So that's what the marketing said when it came. It's the posh insulin. It's the new kid on the block, and it's the more expensive kid on the block. And then the question comes: are analog insulins, the posh insulins, actually better than human insulins? Because we are paying more for that. The patients will pay more for that. Country will pay more for that. Are they really better? And there's a lot of doubt about it still. So far, the only advantages which medical researchers have found with the use of human analog insulin is they don't cause much hypoglycemia in between meals, especially in the night. Now, we know that we have the last meal in the night and next meal in the morning. So that's a fairly long period, intermeal period, and people are likely to go into hypoglycemia at that time. And then especially the elderly. So analog insulins, the posh ones, have been shown to show less hypoglycemia. And the other advantage is, now we know that human insulins take about half an hour to act. Even the short-acting ones take about half an hour to act. So if we are using human insulin, ideally we must inject ourselves about half an hour before the meal, and then have the meal. Now that can be a bit difficult because say you go to a party or something like that, you have no idea what time the host is going to give the dinner, and dinner is on the table, and suddenly they say, come, let's eat or something. You don't have time to inject yourself. Even at home, it can be quite difficult to predict exactly what time you're going to eat. So half an hour early is difficult. The one little advantage of an analog insulin is its action is very rapid onset. So it can be taken just before a meal, So from that point of also, it is more convenient. But if you really look at the cost increase in giving the posh insulins like analogs, we wonder whether it's really worth spending so much of money just to get these two advantages, like a little less hypoglycemia and a little more convenience. Now, why do we treat diabetes? If somebody can ask you, why do we treat diabetes at all? Let's leave diabetes. Shall we say? Why do we treat hypertension? Hypertension is an asymptomatic disease. Why do we treat? Because it causes complications which can be quite deadly. Diabetes is, of course, symptomatic, but we treat diabetes for two purposes. One is to take away the symptoms like polyuria, polydipsia, weight loss, etc. The second reason that we treat is we want to prevent them from dying from a heart attack or getting a stroke or getting kidney failure or losing their eyesight, etc. So what is important to note is analog insulin so far have not shown any cardiovascular risk reduction or cardiovascular benefits in compared to the human insulins. So we must be very clear when we use more posh, more expensive insulin as to what are the advantages and the not so advantageous things about using analog insulin. Give me a second. My slide is not moving. It will move. Okay. Right. Now this is an important slide. I hope you will see because now there are lots of promotions of different types of insulins. So we'll just look at this chart to see where we are. Now, when we come, there are three types of fundamentally, when it comes to duration of action, three durations. One is there are short acting insulins, there are intermediate acting insulins, and long acting. Intermediate might be about 16, 18 hours. Long acting is supposedly 24 hours or a little more. And short acting is maybe about 4 to 6 hours or so. So there are different types of insulins, which now if you look at human insulin, we usually use the word soluble insulin. I'm not, that must be because it looks like water. But the correct word for human insulin, which is short acting, is regular insulin. So we decide to put somebody on regular insulin 3 times a day or whatever. Then intermediate is what is called isophane insulin. It's a neutral protaminated. When you add protamine, it acts longer. Now, we often call the longer acting insulin the word lente insulin. There is something called lente and ultra lente, but that is not actually available in Sri Lanka. If you go to the ward, and it must be available in the private sector, but not in the hospitals. If you look at the hospital, go and look at the hospital insulin vial. The lente, so-called lente, is actually an isophane insulin, which is intermediate acting. There are lente and ultra lente, but they are hardly available. So we are generally dealing with, when it comes to human insulin, 2 types of human insulins, regular or NPH. Now, both of these can be delivered from a syringe and a vial, or a pen and a cartridge both. Then, of course, some other, there are 3 large insulin manufacturing companies in the world: Novo Nordisk, Eli Lilly, and Sanofi Aventis. So you might have heard these names. People talk about Actrapid, Humulin R, then something called Insulatard, Humulin N. All of these are trade names from different companies for the regular and the isophane insulin. Now, we have another very ingenious type of insulin, because we know that we need we'll talk about that later, about the insulin secretion. We need both short and long acting insulins in the body, and companies went on to make a mixed insulin where there is short component, short acting, 30% will be regular and 70% will be NPH. So that's called a premix 30/70 insulin. And there are again the three companies manufacture in under different names. You might see in the hospitals. Something called Mixta, there's something called Mixta 30, Humulin 30, Insuman, they have 25 and 75, etc. But now all the hospital insulins come from an Indian company. It's called Vosulin. It is a fairly new thing, but these are the traditional things which have been there for a long period of time. But there's a new Indian company which makes similar insulin. Now that's the human insulin range. But if you look at the analog insulins, when it comes to short acting, on the human side we have regular, but on the analog side we have things called aspart, lispro, glulicine. You may have heard these names. And different companies manufacture this, something called Novorapid, Humalog, Gapidra. So all these names keep coming up, but they are referring to aspart, lispro, and glulicine. Intermediate acting, it's not so much available in this country. There is, at least there is no analog. The analog, we have the short acting, and the analog, we have the long acting. We don't go for analog intermediate. There is an insulin, long acting insulin called Glargine, Detamert, Degludec. Degludec is the longest acting. And these companies manufacture them as Lantus and Levemir. You may have heard these insulins. So that's the, when it comes to the long acting, the Lentea, ultralentic comparable analog insulins are the Glargines, Detamert, and Degludec. Then the mixed insulins also, there are analog mixed. There is something called Novomix, Humalog mix. They have analog and protaminated analog, which are acting always the short acting is 30 and long acting is 70. So that's the lot. So when you look at this slide, what you must remember from this slide is when it comes to human insulins, we have short acting, intermediate acting, and pre-mixed. And then when it comes to analog insulins, there are short acting, long acting, and pre-mixed. And I've put in yellow perhaps the one which is most used, maybe 90% or 95% of the time, we are dealing with very simple insulins, regular, NPH, and pre-mixed. So let's take the discussion from there. Now, it is important to be aware of the costs. If we go for the insulin bottle and the syringe, one of those bottles will have about 1,000 units, and it costs roughly about 2,700. So that's 270 per unit, 270 per unit. And each of the cartridge, when it comes to cartridges of human insulins, cost about 1,400 for 300 units. Analog, almost twice, 2,600 for analog cartridge. Now, forget that, but let's look at a patient who is on, say, we decide to give 20 units in the morning and 10 units in the evening. So that's 30 units a day. Now, I've made a rough calculation. If you give 30 units a day from each of the three, what will happen? If you give from the syringe and the bottle, for 30 units a day, a patient will need, if they're going to buy from the private sector, about 2,500 rupees per month. And it is available in the government sector as well. I don't know for how long, but we have it at the moment. Then if we use human insulin with a pen, 30 units a day, it will cost the patient about 4,000 rupees. Now compare this with empagliflozin, which costs about 150 rupees a day, even if you give about 25 milligrams. And for 30 days, that's 4,500. So actually using an insulin pen and giving human insulin 30 units a day is less expensive than giving somebody empagliflozin 25 milligram, 1 tablet a day. So there is a definite cost benefit for the patient, even if the patient were using an insulin pen. Of course, if we become really posh, and if your patient is really wealthy, you can go for an analog insulin. It will cost 30 units a day, 8,000 rupees. So that's the kind of, for 30 units, this is the kind of rough cost. it is important when you start somebody on insulin to give them an idea as to how much they'll have to spend. So 30 units, 2,400, 4,000, 8,000, some roughly there. Now, when we think about how we are going to start insulin, it is important to look at this. Now, we have two levels of insulin secretion. With every meal, there is insulin secretion from the pancreas. And when the pancreas is failing in diabetes, what we do is we give them what's called a prandial injection. With the meal, we give an injection. Those are the peaks that we'll see. Of course, the liver will continue to produce glucose even in between meals. And once a meal is taken, it might take some time for the glucose to be absorbed as well. So we need a basal level of insulin. We need some degree of insulin to be secreted every minute of our day. So that's called basal insulin secretion. And that looks after the intermeal period. Meals are looked after by the prandial insulin injections, and intermeal period will be looked after by the basal insulin secretion. So we'll have to keep that in mind when we decide what we're going to do. Now, patients in, just one moment, patients in, if you're going to start patients on an insulin, we know that patients are not very happy to take insulin also. Patients are quite reticent or reluctant to take insulin. It takes a lot of convincing to take insulin. So one of the ways to, easier ways to do that is, rather than saying you're going to need 2 injections or 3 injections or 4 injections a day, to start them on 1 injection a day. That's a basal insulin. So we can give something like, NPH insulin, which is available in the hospital, or a long-acting analog like, insulin Determa or Leverma or something like that. Just 1 injection a day, 1 injection a day. And how do we calculate how much to give? We say roughly 0.1 to 0.2 units per kilogram. Roughly our people are about, shall we say, 50 kilos. We go maximum maybe about 10 units of basal insulin per day. 10 units is a good area to start. And then that basal insulin will cover the intermeal period, overnight, in the night, and fasting glycemia. So that's the basal insulin secretion. When do we give that? Traditionally, it is given in the night. Some people are worried about giving in the night and thinking that the patient might go into hypoglycemia in the night. That has not been shown to occur. So you can give it in the night or morning, whatever, same time every day. You can give 1 insulin injection. And then, of course, you combine that with an oral anti-diabetic agent. The best is metformin. Though we've had so many other medicines and injectables which have come, so far after insulin, metformin is probably the best medicine. And even maybe better than insulin also in some respects. But so metformin is the best. It has a lot of advantages, including cardiovascular protection. So we will combine the basal insulin with metformin. Having said that, if there are some indications, we may consider adding an empagliflozin and or pioglitazone because those 2 medicines have been shown to enhance insulin action, but they have their own problems. Empagliflozin, for instance, is an expensive medicine, and it causes a lot of fungal infections in urinary fungal infections, dental candidiasis, etc., so which can be quite troublesome to patients. There are rare side effects like, where people can go into diabetic ketoacidosis with normal blood sugar level, but those are rare things. But commonly they get a lot of fungal infections, they get balanitis, they get vaginal candidiasis, etc., and very expensive. Pioglitazone again causes ankle edema, and then in a patient, vulnerable patient, may precipitate heart failure. You have to be careful of that. Rare side effects like fractures, etc., but those are rare. So we can combine metformin with empagliflozin and pioglitazone, also being aware of the cost and any side effects that might come. But certainly, yes, they will enhance. To start with, I think it might be quite reasonable to give basal insulin along with metformin. What is not useful is what we very often do, to give gliclazide and sitagliptin, both of which are not likely to be of any, not likely to be enhancing basal insulin action. And also, by the time we go for basal insulin, we have accepted that glycoside is, for instance, no longer able to make the pancreas secrete even more insulin. Now the pancreas is packed up, it's gone, it's not unable to secrete insulin. We accept defeat. So that's why we are going for insulin. And we are trying to give medicines which are going to improve the action of insulin. Then, of course, we must check fasting blood sugar and HbA1c. As I told you, basal insulin's the advantage is it controls the fasting blood sugar, but at times postprandial it may not be controlled. So in addition to the FBS we must look to make sure that they are not going to hypoglycemia, but we must look at the HbA1c to make sure that they have overall glycemic controls as well. The problem is patients may have nocturnal or early morning hypoglycemia with a basal. Now, if the glycemic controls, for instance, fasting is okay, but HbA1c is not good, next step is to give basal plus one prandial injection. That is, prandial means a short acting. We can give regular, or if you're going for analog, a rapid acting analog, RAA. RAA means rapid acting analog, either regular or RAA, with the biggest meal. Now, for us in Sri Lanka, mostly it's lunch, so we give with lunch. So we give a basal in the night and one rapid acting insulin during lunch. We can start with about 4 units. We started with about 10 units basal. Here we go for 4 units. So ideally, this patient will be on isophane insulin 10 units in the night and regular insulin 4 units after lunch. The second option is, if you are going for 2 injections, of course, to take the basal. Now, the basal which you started, stop the basal completely and go for a mixed insulin twice daily. So that's another option that you can take. There is, to my knowledge, there's no evidence comparing these two to look at what is better in glycemic control. So we can go for mixed insulins twice daily as well. So there are the mixed human insulins which have NPH and regular at a proportion of, I put it the wrong way, NPH is 70 and regular is 30. So that insulin is available, you know, what we usually refer to as Mixtard. Mixtard is a brand name, or a mixed analog. They are also available, you know, Humalog, etc. So one of those two we can go for morning and evening, and the starting dose may be 0.2 units per kilogram kind of thing. So we don't start at a very large, maybe we might start about, I don't know, maybe about 6 and 4 or something like that in the morning. Some people believe that it should be 2/3 in the morning and 1/3 in the evening. That sounds logical because we eat more from morning and less in the night. So if we are going to give, shall we say, 10 units in the morning and 5 units in the evening, so that's 15 units altogether. So we give 2/3 out of the 15 units in the morning and 1/3 in the night. That's a rough practice that people do. Again, I don't think anybody's really looked at the evidence to say whether that is the best combination, but that's what we usually do. Now, ideal insulin is what's called a 4 injection regime, what's called the basal bolus. So we are trying to be very physiological, giving a basal dose in the night, and with every meal, a prandial, a regular or rapid acting analog with each meal. Now, this is great, but only thing is patients hate this because they get pricked 4 times a day. We might try to do this with type 1 mostly, but even type 2, if somebody is willing to go for this, this is ideal, but it will be very difficult for you to find a patient who is going to be happy with a basal bolus. So usual recall, what we do is, so if you look at the stepwise, how we go for a basal first, maybe 10 units, basal plus prandial with the large one, 10 and 4, or stop the basal and go for a pre-mixed twice daily. And finally, if we can't get anywhere with our glycemic control, we suggest to the patient a basal bolus 4 injection regime. So how should insulin dose be adjusted? It is essential for patients to have a glucometer if they are going to be on insulin, and we have a concept called SMBG, that is self-monitoring of blood glucose. Some patients are very committed; they will check blood sugar every morning before meals. There are all sorts of glucometers available. Most glucometers come and then they disappear, and the patient, at least the strips disappear, and the patients are left with a useless glucometer. I'm not promoting any particular glucometer, but what I have seen is over the years is something called one touch has stayed with the strips for a long period of time. So that has been something which has been good, but there might be other glucometers which last. I'm not an expert about glucometers. So just make sure that you get your patient a good glucometer where they will continue to have strips in time to come. And then of course, we can teach the patient if the fasting blood sugar, when they not fasting but capillary blood sugar before meals, if the blood sugar is more than about 120 or the pre-dinner CBS is about more than 200, we can tell them, look, if the morning blood sugar is more than what we want, you can increase 2 units in the night. The previous night's insulin is the one which reflects this morning's blood sugar. So if the morning blood sugar is a little high, we increase the night insulin dose by 2 units. And if the dinner CBS is a bit high, we increase the morning insulin by about 2 units. So that's how we would teach the patient to adjust the doses, never more than 2 units a day, because otherwise they'll go into hypoglycemia, and then ask them to keep a good record and come and show you when they visit you. So what is the essential advice that needs to be given to patients who have been started on insulin? One is, when we are starting, we need to look at the cost, very important, and the injection regime, whether the cost patient can bear, especially if you are giving insulin pen. The injection regime, whether that fits in with the patient's job. Now, for instance, if I'm going to start insulin on a patient who is going to drive a highway bus between Galle and Colombo, I have to make sure that my insulin regime that I'm suggesting is within his bus driving schedule. So we need to be very mindful of who our patient is. Then, of course, make sure that the patient knows how to inject himself, and then monitor the blood sugars, and how the patient's preference in all this is. Next important thing is to inject by self. They have to, because a lot of people are very happy to get injected by their daughters or sisters or husbands or wives. The problem is, if that person even for a day goes out of home for something, the patient will be without insulin. So patient needs to be taught how to take insulin. Then of course, if they can at least once a week do a self-monitoring of the blood glucose, it's also an expensive thing. Glucose strips are quite expensive, so we can't ask them to do every day. So, and then of course, if you are going to prescribe human insulin pen, you must put the patient in touch with the rep who is doing that insulin, so that if there is the slightest problem with the pen, etc., they will call the area rep and then ask them to replace the pen, because otherwise they will wait without taking the insulin, and maybe for an appointment to see you, that might take 2 or 3 days, and the patient might become quite ill. So there has to be a backup mechanism available if the pen fails, or if they have some problem, that they speak to somebody. And then of course, tell the patients never to stop insulin, even if they are ill and unable to eat. We know that when patients are very ill, they may need more insulin than normal. So we need to tell them never stop insulin, do a blood sugar even if you're ill, and at least continue half dose, because patients are very reluctant to take the full dose if they're not eating. Family is very reluctant to give the same insulin dose. So compromise choices, tell them at least to take half the dose, so everybody is comfortable with that. I think that brings me to the end of the talk. Himal, do I take questions now, or do we look at the MCQ?
So we will look at the MCQ first, and we'll go to the question later.
Right. Yeah. Okay. Just give me a second. I will try to now share the MCQ. All right. Can you all see? Himal, can you see?
Yes, sir. We can see.
Right. Okay. So let's look at the insulins, the MCQs. I'm sure Himal would have sent all of you the MCQ earlier. So just to look at this, which one of the following medicines should be used in combination when starting just when starting the patient on insulin. Metformin, glycoside, sitagliptin, empagliflozin, and pioglitazone. So since we are not going to have people answering, I will discuss the MCQ myself. Now again, you know the type of single best response. Most of the time, some of the more than one answer can be correct. As we discussed, glycoside and sitagliptin, there is no place to be continued when we are going to start the patient on insulin. We have now accepted defeat. We know that the pancreas can't secrete any more insulin, so there's no point in trying to flog the pancreas. So we can give metformin, empagliflozin, pioglitazone, but empagliflozin and pioglitazone need not be combined with every patient whenever we start insulin. But metformin certainly yes, because then you can reduce the amount of insulin that the patient is given. So I would take number 1 as the answer, metformin. Which one of the following medicines should be used in combination when starting the patient on insulin? Pioglitazone and empagliflozin can also be started, but they do not fall into the category of should be started. Okay, so this is the single best response. Okay, so single best response, I'm sure most of you know, there is more than one correct answer, but we are going for the best possible answer, especially for medical students. If you all are here, best possible. In which one of the following situations is it essential to use insulin? Essential to use. When I'm karanda patients undergoing surgery, patients with sepsis, having an acute MI, patients who are being discharged after recovering from DKA, patients with type 2 diabetes with HbA1c of more than 10. Again, if you look at all 5 answers are correct. They can be used. In all these things, it is actually quite good to use insulin in somebody undergoing surgery, sepsis, acute MI, but these patients, what is important in these conditions is blood sugar control. So if you can achieve blood sugar control with oral hypoglycemics, patient is on oral hypoglycemics, patient is coming for an appendicectomy, patient's blood sugar is, fasting blood sugar is 90, HbA1c has been 5.8, you don't have to put them on insulin. You can just continue the same medicine, that will be fine. So insulin can be given in these conditions, but it is not essential. If blood sugar can be controlled with these, that's fine. With orals, that's fine. Then even for HbA1c of more than 10, again, we must think about giving insulin. We must certainly think about giving insulin to prevent glycemic toxicity, but it is not essential again to give insulin. But for any, as we discussed earlier, but for any patient who has had DK in the past, it is essential that they be discharged on insulin. Okay,
Sir, we can hear. Yes, sir, we do.
Right. The third single best response, again, remember, there may be more than one answer. We are going for the best. The patient has been on basal insulin for 6 months. Fasting blood sugar is 70. HbA1c is 8.2. The most appropriate next step in management is, so let's look for, now this is what we discussed. Basal insulin tackles intermeal glycemia and fasting glycemia. So FBS is fine, but it may not cover the prandial glucose loads. So that's why the HbA1c has gone up to 8.2. So one is increase basal insulin to twice a day regime. There is no basal insulin twice a day regime. This is an incorrect answer. Start prandial insulin injection. That is a correct answer. Start a basal bolus regime. That is correct, but that is usually not, just because we see an HbA1c of 8.2 with FBS of 70, that is not the way to go for a basal bolus, because basal bolus has a lot of problems. That is a correct answer, probably not the best answer. Add twice a day pre-mixed insulin. That is again a correct answer. That is quite correct. We'll look at, and the next is omit basal insulin and start 3 times a day prandial injection. That we know is a wrong answer. 3 times a day prandial alone is not going to be sufficient, because when somebody is having a failing pancreas, it is not sufficient to give prandial insulin alone because they are unable to secrete, during the whole day insulin. So obviously 1 and 5 are not acceptable. 3 is also not acceptable. So our choice lies between add twice a day premixed insulin or start a prandial. Now look at the wording here. This says add twice a day. So add means to the basal to add premix twice a day. Now that is never done. So that leaves our answer as start prandial insulin injections or start a prandial insulin injection. Now, if in answer 4 it had been start twice a day premixed insulin, then that would have also been an equally correct answer. Of course, we will not give equally correct answers too. So you can see why you must read the MCQ very carefully, because it says not start but add twice a day premixed insulin. So we never add premixed insulin to basal insulin. Okay, right. Then of course we have true false. Put true false as advantages of analog insulins over human insulins include less incidence of diabetic nephropathy, less incidence of diabetic retinopathy, less incidence of hypoglycemia. That is correct, but the first two ones are wrong because we studied earlier that analog insulins do not cause less complications in terms of macrovascular and microvascular, but certainly it causes less incidence of hypoglycemia. That is a correct answer. Less incidence of cardiovascular disease. That is also a wrong answer. Ability to take insulin immediately before starting the meal. That is a correct answer. So the only two advantages of analog insulins over human insulins are ability to take insulin immediately before starting a meal and a less incidence of hypoglycemia. Other things are wrong answers. Methods of administration of insulin for long-term control of diabetes include subcutaneous, yes. Subcutaneous injections, yes. Subcutaneous infusions, not for long-term control of diabetes. It can be used for short-term. Infusion means through an infusion pump or something we give every day. Or subcutaneous infusions. This is a correct answer because if we are looking at infusion pumps, then this becomes a correct answer. We are usually in our country, we are used to insulin infusions in the acute stage, but for long-term control, also diabetes, insulin pumps can give subcutaneous infusion. Use insulin patches for dermal absorption. Dermal absorption, we have testosterone, we have things like fentanyl for pain relief, but no insulin. And then we have nicotine patches. Those are the usual patches that you would see, nicotine patches. Fentanyl patches for pain relief and testosterone patches for hypogonadism, but there are no insulin patches. Intramuscular injections are not used for long-term control of diabetes. Intramuscular absorption is very erratic. So one of the problems when we give patients insulin bottle and the syringes, at times inadvertently they go and inject into the muscles, and that can cause erratic insulin absorption, poor glycemic control, plus hypoglycemia, anything. So that's a wrong answer. And then inhalation is a correct answer. Inhalation insulin not available in Sri Lanka. But still it's available worldwide. So these things are coming up. So subcutaneous injections correct answer, subcutaneous infusions correct answer, and inhalation correct answer. Hima, I have finished
Yes.
MCQs also. I hope I wasn't too rapid in the way that I did this. If there is any question or something, I'll be happy to take any questions, Hima.
Yes, we have about 9 questions taken from the audience.
Yeah.
So first question I'll move, sir.
Yeah.
What is the sliding scale to treat hyperglycemia, and is it recommended in every patient with marked hyperglycemia?
Sliding scale is perhaps a failed regime. Again, one thing is nobody has done any research on this. Sliding scale is a failed regime. That is what will happen is if the blood sugar once the blood sugar is controlled, we let go of control. Now if the blood sugar sliding scale will say if it's less than 140, don't give insulin. And the next time you measure, it will be 340. So sliding scale is it's a failed regime. It should not be used. What should be used is a either a continuous insulin infusion where we regularly check the blood sugar and adjust the insulin infusion rate. That is one option. Second thing is very simple. Go for a, go for 3 times a day, 3 times a day regular injections. But before each meal, check the blood sugar and increase or decrease, but stick to it. Now, shall I say I start 10 units 3 times a day and I check the blood sugar before lunch and it becomes 220. So I will make next day's regime 10, 14, 10. And in the night, if I check again the blood sugar is high, I might make it 10, 14, 14. So 3 times a day insulin injections. If you make a change, stick with the change and carry on. The problem with a sliding scale is the moment blood sugar gets controlled, we let go of it. And the next reading, I'm sure you all have seen, next reading comes as 250 or 350 or comes as a high reading. And then you are again down to giving large dose of insulin. So you just swing between large and small doses of insulin. I hope that is enough, Himar.
Yes, sir. Very well. Second question: How do we calculate number of insulin units according to the FBS, HbA1c, and how we titrate those units to achieve the target of blood sugar levels?
Yeah, as I've told you, if you're going for, all we have to decide is how much are we going to start with. How much are we going to start with? So if you're going to start with a basal, maximum we give is about 0.2 per kilogram. Even for mixed insulins, I think the rough guide, remember, if you have to use more than about 0.5, that's a lot of insulin, 0.5 units per kilogram of body weight. So that's considered a very large. So you go for, I would suggest that you start maybe 0.2 units per kilogram. Shall we say we are looking at a 50 kilogram man, 0.2 is about 10 units. So you start with 6 and 4 initially, and then keep adjusting the dose as I described to you. If you look at the blood sugar, maybe just before dinner, look at the blood sugar. If it's more than 200, go up by 2 units. And if it's go up by 2 units, the morning dose, if you're going for a premix. So start with a small dose. There is no hurry to get the blood sugar controlled very rapidly. You can take a few weeks to get there. Start with a small dose, because if you start with a large dose and the patient gets hypoglycemia, they'll get scared for life. They will never take insulin again, because hypoglycemia and unconsciousness can be frightening experiences for patients. So start with a small dose, shall we say 0.2 units per kilogram of body weight, and then mixed insulin. You can start, if you're going to start mixed insulin or basal or whatever, 0.2, and then keep adjusting the dose thereafter, looking at the blood sugars. That's what I would suggest. Not to start with a high dose straight away. There is no hurry. Now, even if you see a blood sugar of 350 today, it doesn't mean that the blood sugar became 350 yesterday. Blood sugar would have been 345 1 week earlier. 1 month earlier, it would have been 336 or something like that. So there is no need to hurry. Start with a small dose. You know that the patient is safe, and thereafter adjust the dose. Thank you, Himar.
Sure. Next question is, when do we need to do fasting blood sugar or PPBS and HbA1c after the insulin? What I think the audience is asking, the frequency we are doing the
frequency, yes. Yes, I mean, I think a reasonable, soon after starting, of course, we might have to do a fasting blood sugar, maybe, once a week or something like that for the first month. But if you're looking at a patient who is long-term on insulin, fasting blood sugar once a month should be okay. But remembering that fasting blood sugar is a poor indicator of how glycemic control is. We are looking at fasting blood sugar looks at overnight glycemic control. PPBS is again not a very useful medicine test unless you are looking for specifically for postprandial hyperglycemia. I would suggest that we stick to fasting blood sugar and HbA1c. Ideally, HbA1c should be sufficient for all our measures. If we can do every 3 or 4 months HbA1c, but HbA1c is quite expensive. So shall we say, I try to do HbA1c once every 6 months or so, because it's an expensive test. And in between, I might use fasting blood sugars to know where we are. Okay.
Sure. So a lot of questions are coming the line of basal insulin and uses. What are the instances we can use basal insulin alone, and instances with the combination of regular insulin?
Yeah, it's whenever we give insulin for a patient. Now, I'm sure you all, and because you all are seeing patients who have the same problems that I have, patients are very reluctant to take insulin injections, and it is very difficult to convince them to straight away go for two injection regimes. And if you look at the if you look at the literature as well, even if you look at the very latest guidelines of management of diabetes, what is recommended is to give a basal insulin dose as the first step in the conversion from oral to insulin. So basal insulin, one dose in the night, maybe up to about 10 units a day, and then we can see where we are. And if we are running into problems, we have two choices. One is to backtrack, stop the basal, go for a twice daily, or add a prandial to the basal. So basal is a good one to start. Of course, if your patient is willing to go for two injections, you could bypass the basal step and straight away go for mixed insulins. But remember, the mixed insulins have a problem. I'll tell you what the problem is. Now, the mixed insulins originated in the West. If you look at the Western lifestyle, patients have a big breakfast. They might have 3 eggs and, 6 sausages and, so much of, they eat so much. And they have a fairly large meal for dinner as well, but they hardly eat anything for lunch. They might get along with a sandwich. Whereas in our case, our lunch is our biggest meal. Now, when we go for a pre-mixed twice daily insulin regime, the major problem is we don't cover lunch. And that is perhaps one of the reasons why when we give twice daily, we have such difficulty in controlling the HbA1c. Because you all realize, in the morning, you take a basal and a short acting. In the night, you take a basal and a short acting. That's fine. Those two meals are covered. Lunch, which is our biggest meal, our entire Batpingana is covered only with a basal insulin. So that is probably the biggest problem that we have with the twice daily. So so we can give twice. Now, I will just tell you all, again, this is not evidence-based. Now, if I am running into problems with twice daily insulin and still the HbA1c is high, I actually add the prandial regular insulin at lunchtime to our patients. So what I might do give a kind of like a mixed start, say 16 and 10 morning and evening, but cover lunch with regular insulin about 6 units or whatever. So that is one way to overcome this twice daily mixing. But that again, we are talking about 3 injections. So patients are again quite unhappy to have 3 injections, and they need 2 pens actually for that. If they are going to use the pens, they're going to have 2 bottles. Okay, anything else, Hima?
Yes, sir. The next question, when we can go back to oral hypoglycemic agent after insulin with confidently, after achieving HbA1c values? I think they asked.
I think you're talking about the initial diagnosis when we find the HbA1c which is high. Usually what happens is the chronic hyperglycemia has made the pancreas kind of tired or insensitive initially. So the pancreatic insulin secretion is minimal when somebody is diagnosed as having diabetes. So when we give insulin, then the pancreas kind of rests. We give insulin from outside, we get the blood sugar into control. I don't think that there is anything, I have not read anything which tells us when exactly we can go back to oral. But if once the blood sugar control, if once the HbA1c, say you give it for a couple of months, and if the HbA1c drops to, say, shall we say 6.3 or something like that, I think it's fairly safe at that time, because you will be giving metformin or anyway. At that time, it might be useful to go for oral. Now, having said, speaking a little bit oral, which is not part of this topic, glycoside is probably the most effective. Sulfonyl urellas are very effective in bringing blood sugar, but they are the least useful when it comes to preventing cardiovascular adverse outcomes. So ideally, they should be pushed back in the oral hypoglycemic order, because all other medicines, empagliflozin, dapagliflozin, they are now coming up as after metformin, they are probably the best medicines. That's what the evidence emerging. If the patient can afford, we can add one of those, and then things like DPP4 inhibitors, etc. There are others, but glycoside is quite effective. It's quite effective, and it can drop the blood sugar very quickly if you want. So yes, answer to the question, once the HbA1c comes back to normal, then we can maybe lessen the insulin dose for some time, give more oral, and then stop the insulin and watch.
Sure, sir. The next question is very practical problem in these days. This is we are facing a shortage of pre-mix insulin in government sector. Do we have any alternative for the insulin?
You have actually, you may not know now, this is long before your time. When I was, maybe I was a house officer at that time, we didn't have pre-mixed insulin in the hospitals. So we used to teach patients to draw insulin from 2 bottles and make their own mixed insulin. So we used to teach patients first to draw from the clear fluid, that's the regular. How much regular? So that 70-30, that's the proportion, 30% regular and 70% long acting. So we teach the patient, you draw 3 units from the clear insulin bottle into the syringe, and then you put that syringe into the milky kiripata bottle and draw 6 units from that, mix it in the syringe and give it. And actually, if you read the literature, my teacher, Professor Devaka Fernando, has done published research on this. It is definitely available. If you can do a Google search, I think it was published in the CMJ about patient mixed regime. That was a time when there was no mixed start. So what Prof did was, we had only long acting. We had this isofene insulin, which was being given to patients twice a day. He compared that with the patient mixed regime and showed that patients can actually mix and have a mixed insulin, and that it was effective. So yes, at times like this, when we are in crisis, we need to look at some of the successful things which happened in the past and adopt that. Yes, that can be done. That can be done. There is research to prove that. Remember, if you draw from the kiripata bottle first and put that syringe into the clear bottle gets spoiled. So patients have been told very clearly that they have to first draw from the clear bottle and then put to the kiripata bottle, which is the isofene insulin. Okay, Hima?
Exactly, sir. Sir, last question. A lot of question, as I said, comes with the regarding basal insulin. What are the OHs we can continue with basal insulin? I think you have answered the question, but still our audience has doubts.
Sure. Yeah. Number 1, always metformin unless there is a strong contraindication. Strong contraindications for metformin use are very few actually. Patients with EGFR of less than 30 or so, we advise to stop metformin. And then of course some people get severe loss of appetite, and then they get nausea and vomiting. So those are the only side effects of metformin. It's one of the most wonderful medicines ever discovered. Metformin, one of the greatest medical discoveries. So yes, metformin always with the basal insulin. You may add quite usefully empagliflozin and pioglitazone, remembering the cost addition as well as some other common side effects of those 2 medicines. Those are useful. So actually, if you want, you can give basal, metformin 1 gram BD, empagliflozin 25 milligrams a day, pioglitazone 30 milligrams a day. I think that's quite an effective way to set about. There is no place theoretically and practically to continue gliclazide and sitagliptin, because what those 2 medicines do is, now pioglitazone and empagliflozin and metformin all have an action of increasing sensitivity of the insulin that you're giving. Whereas if you look at sitagliptin and gliclazide, what they're trying to do is to get the pancreas to further secrete insulin. Now, when we know that the patient has OHA failure, and then we are going for insulin, there may not be much use in giving gliclazide and sitagliptin. But of course, having said that, if you're going to give basal insulin for a patient at the initial diagnosis when the HbA1c is very high, then of course you can combine that with even glycoside, that should be fine.
Right, sir. That will be all for the questions today. And let me thank you again for joining with us in this the valuable discuss the valuable topic with our audience. I'm sure a lot of our audience got many things with this lecture. Actually, we had over 250 participants to these sessions. Thank you very much, sir, for joining us with the short notice, and we will hope your sessions in future as well.
Thank you, Himal. Thank you. It has been an absolute pleasure to join you. Continue your good work. This is what really the kind of work that you all do. Reaching out to all doctors in the country is what will actually make a realistic difference in patient care in this country. So good luck to all the junior doctors and medical students who have joined in. Feel free to contact me if you want anything at all. And Himal, thank you very much. It has been a pleasure. And if at any time you want me to speak again, I'll be very happy to do that. Thank you. And thank you, thank you, Nandini, as well.
Thank you. And let me thank Sri Lankan College of Internal Medicine and its current president, Dr. Kumudini Jaising, and past president, Dr. Ganaka Seranatha, who has pioneered of this session, and Dr. Nandini Jnanaprakash, coordinating from the college side. And last but not the least, our everyday participating audience. So they are with us for every Sunday in our sessions. Thank you very much for all joining us. And you will be posted link to submit your e-certificate details, and you can submit it. It will be available in the session. And after all, let me wind up session. Thank you all. Thank you for joining us. Thank you. We will hope another session in next Sunday.